Hyperthyroidism, Graves' disease, toxic Hashimoto's. So what is all of this? I have a lot of you guys asking me questions about, can I explain hyperthyroidism? So here we go. I'm Dr. Cassie Smith. I'm an endocrinologist. If you like this information, please make sure you subscribe, hit the notification button. That way you can be notified when I drop new content like this. And make sure you comment below to let me know if you have further questions or what you want to hear me talk about. I think the easiest way to do this is with a whiteboard. So I'm a very visual learner, and you can ask my patients. I like to draw pictures and write stuff everywhere. So this is what we're gonna do. This is your thyroid. Disclaimer, I'm not an artist, but this is your thyroid gland. This is your pituitary. So your brain has a gland in it called your pituitary gland. If you did not catch my endocrinology video that's on YouTube where I explain everything about endocrinology, you should definitely check that out. A gland in the middle of your brain called your pituitary gland. This is our master hormone gland. So this makes something called TSH. Thyroid-stimulating hormone. This is important because this is our thyroid signal to make thyroid hormone. So TSH will then come to the thyroid, and it stimulates the thyroid when it gets here to make something called free T4 and free T3. These are active thyroid hormones. This is what goes to cells in our body and tells our cells to make our hair grow and make our nails grow, make our metabolism work, to not be cold, to help regulate everything thyroid helps regulate. Temperature, sex hormones, sex drive, all of those things. So you have blood levels of T4 and T3 that then feed back to your pituitary gland, and your pituitary gland determines whether there is enough free T3 and enough free T4 in your blood. If there is, there's a constant stream of TSH being made, and so this just all stays in flux. If your body feels like there is not enough free T3 and there is not enough free T4, it is then going to stimulate an upregulation of TSH in your brain, causing more TSH to be made from the pituitary gland, and then this is in turn going to cause more TSH to come into the thyroid and more free T3 and more free T4 to be made. Once these levels start to go up and they're no longer being sensed as being low, then this will feed back to the brain, and the brain will say, okay, I'm happy, and it will not have to upregulation of TSH. So this is how it all works. So the problem will lie if you have too much TSH. So there are conditions where your brain makes more TSH. So it's making TSH and it's making TSH, even though your free T3 and free T4 levels are high. These free T4 levels, this means in excess of 2, and then a free T3 level in excess of 5, not on thyroid medication. If these levels are high, when this goes back to your brain should sense, oh my gosh, that is too much thyroid hormone, and it should down-regulate TSH. So it should say, okay, I don't need any more of this. Let's stop making this. There's plenty of this in the blood. However, there are conditions, which I've listed over here, where this doesn't happen. So hyperthyroidism is when these levels are high, they're going to the brain, your brain is sensing that these levels are high, and it's down-regulating TSH. It's making less TSH, it's trying to make no TSH because it realizes these levels are high. So when this happens, the question is, why is it happening? So what you're gonna see is your TSH is gonna be low because your brain is not making any. Sometimes it's less than 0.01. So there's no TSH being made by your brain because your brain senses that your free T4 is high. You can have levels anywhere from 2, I've seen them all the way to 15. You can have free T3 levels, anywhere from 5. I've seen them in excess of 25. And so these are what your labs are gonna look like in a hyperthyroid state. You're gonna have a low TSH because your brain is gonna be like, I don't need to make any more of this hormone because there's plenty of this free floating around. So then the question is, again, why is this happening and how do we fix it? Well, Graves' disease is the most common. Graves is an autoimmune process where your body attacks your own thyroid glands. You have this antibody, and I like to look at them as like little Ys, and this antibody looks very similar to a TSH molecule according to your thyroid. So your body is making these little antibodies that look like TSH. We call these TSI antibodies, thyroid-stimulating immunoglobulin antibodies. But these antibodies will go and they will set on the thyroid and they will cause the thyroid to make more T3 and T4, even though the brain is saying stop. So even though your TSH is low, these antibodies look like TSH and stimulate your thyroid gland to make T4 and T3 when we don't need it. So that is Graves' disease. It's an autoimmune process. Your body's attacking itself. It's making these little antibodies that then go stimulate your thyroid and make your thyroid make T3 and T4 inappropriately. So how do we fix this? How do we know that's what it is? Well, you're gonna have labs that look like this. You're gonna have a low TSH, a high free T3, a high free T4. But if you check this antibody level, you could also check an antibody called a TSH receptor antibody. These levels are going to be high. So if that's high, you know, oh wow, we've got an autoimmune process going on here we need to fix. And that's Graves' disease, okay? And that is sort of the opposite of Hashimoto's if you think about it. So in that case, what we need to do is get this inflammation, these antibodies to go away. The frustrating thing about Graves' disease is that in about 30% of people with Graves, their TSI antibody will not be high. So it will actually be normal, but they have these scary looking labs. And so then you're like, what the heck is going on? In people where this happens, we use a whole other way of determining what is actually causing their hyperthyroidism. Because it's really important to determine whether it's Graves, toxic nodule, thyroiditis, toxic Hashimoto's, because you treat all these things differently. So remember, Graves is this antibody over attacking your thyroid. So what do we do if this antibody comes back normal, but we still think maybe we have Graves? We do something called a thyroid uptake and scan. So thyroid uptake and scan is how we determine, does this person really have Graves? So again, if you look at somebody's thyroid gland, the cool thing about this is that our thyroid gland uptakes something called iodine, and it's one of the only cells in our body that do that, which is why I check iodine level. You need iodine in order to make T4 and in order to make T3. So it's all made on a backbone of something called an iodine molecule. So what you can do in these people is you give them something called radioactive iodine. Sounds really scary, but it just means it's iodine that has a tracer of radioactivity connected to it. And so it's kind of like a light. And so you give people radioactive iodine, they swallow it, we scan their thyroid. And initially, nothing is going to show up. But when they come back 24 hours later, what we're gonna be able to determine is where did that iodine go? If they have Graves' disease or they have an overactive thyroid, all that iodine is gonna go into their thyroid, right? Because their thyroid, the Graves antibody, the one that we talked about, is trying to stimulate this thyroid to make T4 and T3. In order to make these, you need iodine. So when somebody is hyperthyroid, all these antibodies are gonna try to get your thyroid to make T3 and T4, but iodine is needed. So if you give someone a large amount of iodine in a pill form, it's gonna go to the thyroid and the thyroid is gonna take this up and it's gonna start using this iodine to make T4 and T3 everywhere the iodine goes into the cell. And so when these people come back 24 hours later and you scan their neck again, their thyroid is gonna light up like a Christmas tree. So you just see this big white area in their neck where all this iodine has went in. And so if that happens with these labs, then you know they have Graves' disease, even though their antibody was abnormal. Because there's no other reason that when your brain is saying stop and your TSH is low, that should be taken into your thyroid. So that's how you determine whether somebody has Graves' disease. And then the treatment of that is we give them medication to block the production of T4 and T3. So you give them something where these antibodies are not able to bind to the thyroid. So it sits here and it blocks where these antibodies bind, and then your body will not make T3 and T4. Wonder if you give somebody iodine and 24 hours later, you get a scan that shows nothing. So 24 hours later, their thyroid just looks like this. So on the scan, it will be completely black. Well, what that means is their body did not want that iodine. Their thyroid is not trying to make too much T3 and T4. It doesn't need the iodine. But you definitely don't treat them the same as you do with Graves' disease, because if you do, you can end up hurting them. And so if it's not trying to make excessive amounts of T4 and T3, it doesn't need iodine. So the labs will look very similar. Typically your T4 and T3 will not be as high with thyroiditis, but sometimes it can. And so that's the difference. I think of thyroiditis as kind of like a virus, kind of like an angry thyroid, kind of like a tennis elbow, and it stimulates your thyroid and makes your thyroid mad. And so your thyroid just dumps all the T4 and all the T3 that it has stored in it when this virus or whatever happens insults your thyroid. And so all your thyroid hormone comes out and it's really angry, it's inflamed, and so it all comes out. So patients develop symptoms, they come to you. All this blood level of T3 and T4 has fed back to the brain, and the pituitary goes, oh my gosh, I don't need any more thyroid hormones. It downregulates TSH, so you have none. Your free T4 and free T3 seem high. But the good news about thyroiditis is usually within 6 weeks, it fixes itself. So it's dumped all this out. Your body realizes there's too much. It stops making it. As this leaves your body over the next 4 to 6 weeks, your brain will slowly start to make TSH again, and your body will slowly start to make T3 and T4 without any sort of treatment. So that's the difference between thyroiditis and Graves, and the way you can tell is when you do the antibody test and it's negative, you do this radioactive uptake and scan, and then if your scan shows diffuse uptake, you know there's a lot of T4 and T3 still being made, so it's Graves' disease because of the antibodies. But if your scan shows there's nothing, then you know it's a thyroiditis, and you just need to let it pass. There's 2 other things that cause hyperthyroidism. These are much less common. One of them is called a hot nodule or a toxic nodule. And so this happens in people with thyroid nodules. So sometimes there are patients that have thyroid nodules and we either know about them or we don't. But let's say that we have a right upper thyroid nodule right here that's like 2 centimeters. And we know this patient has this nodule. Sometimes these nodules can just over-secrete hormones for whatever reason. So this nodule can be making too much thyroid hormone. So even though the brain is saying, nope, I don't need any TSH and it's somewhat suppressed, this nodule is still making T4 and T3 just because. And so that's important to know as well, because the way you treat this is surgically. You're not gonna give these people medication like Graves. You're not just gonna let them set because the nodule's still gonna stay there. And when you do a thyroid uptake and scan in these people, so when you give them that iodine that we talked about, right? Wherever that nodule is what's gonna light up like a Christmas tree. So if they have just one area of uptake in their thyroid, and you know they have a thyroid nodule there, this is gonna be a hot nodule. And then again, you're gonna surgically remove this. If they have their whole gland that lights up on the uptake and scan, right? It says diffuse uptake and it looks like a Christmas tree. This is gonna be Graves' disease. But if they have nothing that uptakes and they have low uptake, this is gonna be thyroiditis. And again, it's really important to know the difference because you treat all these differently, right? So we're gonna do surgery. We're gonna treat somebody with Graves with something called methimazole. Typically, you can use PTU. We also usually give them propranolol to help with symptoms. And then if it's a thyroiditis, we symptomatically treat them. We can give them propranolol to help with symptoms, but a lot of times we do nothing. We might do some NSAIDs, but we leave them alone because they're gonna fix themselves on their own. So these are the 3 most common causes, and blood test is where you start, and then radioactive uptake and scan. Although it's called radioactive iodine uptake and scan, it's not gonna harm them. It's not super, harmful. It's a small amount of radioactive tracer in the iodine that they give them. And then finally, the last thing is toxic Hashimoto's. Millions of people have Hashimoto's. And a lot of you know that Hashimoto's means your thyroid is under functioning. You have something called a TPO antibody that's causing inflammation. It actually causes hypothyroidism, which increases TSH because you have low free T4 and low free T3, right? So this is the reverse typically with Hashimoto's. But this can turn to what we call toxic Hashimoto's. So it can go from hypo to hyper. Very uncommon, but happens at times. So typically, when you have hyperthyroidism, it's gonna be due to Graves. And again, it's that antibody that looks like a TSH molecule. It mirrors one. Your thyroid doesn't know the difference. And when these antibodies come and they attack your thyroid just says, okay, I'm supposed to make T4, I'm supposed to make T3, even though your brain is like, oh my gosh, there's way too much. And it's down-regulating TSH. So that's kind of a bird's eye view of hyperthyroidism. I've had a lot of people ask about it, so I hope that helps clear it up to some extent. Again, a lot of it is blood tests that we're looking at to help us determine it, but then some people need radioactive iodine. The symptoms of hyperthyroidism: you're losing weight without trying, diarrhea, super hot, very tachycardic, feel like your heart is beating really fast. You can have low blood pressures. Most of the people that present with hyperthyroidism have palpitations, meaning their heart's beating really fast. Sometimes they have syncope or they pass out. Oh, and unexplained weight loss. Dr. Cassie Smith, I'm an endocrinologist. If you thought this was helpful or you liked this, make sure that you subscribe, make sure you hit the notification button, share it with a friend, share it with a colleague. That way, whenever I drop this content, you'll know about it, and then comment below and let me know what you liked, what you didn't like, what else you want to learn about. Have a good day.